commonly. So as we all know, many of our patients with cognitive issues have comorbid conditions and vice versa. And then specifically things like dementia or cognitive impairment can make the management of comorbid conditions more difficult. So if you have a patient with difficult to control diabetes and they are forgetting how to take their medicines or follow their blood sugar, then that creates kind of a vicious cycle. And so evaluating and treating comorbidities has important implications both in the prevention of memory problems and in the treatment of cognitive conditions. So again, we'll just go through kind of a few common ones. So a lot of our patients have vascular risk factors. So hypertension and hyperlipidemia have been associated with an increased risk of cognitive dysfunction and dementia. There's also some concern about hypotension and its potentially negative cognitive effects. So it's a little bit of kind of finding the sweet spot, because there's some concern again with hypotension or hypotensive events that you could get hypoxia, which could affect cognitive function. There has not been a clearly agreed upon goal blood pressure for cognition, but there have been some commissions and groups that have suggested a goal of about less than 130 systolic, which is probably a reasonable goal for most people. And then smoking, diabetes, and obesity have also all been linked to increased risk of dementia. I will also say that for a lot of these things I'm going to talk about, the data is a little bit mixed. So there have been some studies evaluating these things that have not found a clear association, but it's generally agreed upon that these can all be risk factors for cognitive dysfunction. Stroke can increase risk of dementia. So a isolated post-stroke dementia is defined as occurring within 6 months of a stroke. About 10% of patients can develop dementia after a first stroke. And then there's a much higher percentage, up to 33% of people who can develop dementia after a recurrent stroke. And then there have been studies looking at people with specifically subcortical strokes, and 47% of those patients had mild cognitive impairment in one clinical trial. And then there are some strokes that just isolated by themselves can cause cognitive presentation or cognitive issues. So thalamic strokes, hippocampal strokes, strokes in the angular gyrus or basal ganglia, or ACA territory strokes, so frontal lobe strokes, all can present with isolated cognitive changes. So on that note, I'm going to talk about a case. So this is a patient that Dr. Keith and I saw. She was an 80-year-old woman who had hypertension and hyperlipidemia, and we saw her in clinic in October of last year. In July of last year, so a few months before we met her, she had been found on the floor of her home, confused. She was having some hallucinations, and then she had fluctuating symptoms afterwards. So she was hospitalized and had this CT scan. So if you see here, this arrow is pointing to a small right thalamic stroke, which is, again, pretty small when you think about size of infarct, but with strokes, it's always location, location, location. So we worked her up for a lot of other stuff. Another key part of this was that she did not have any history of cognitive issues prior to this. So she had been living independently. She and her daughter both agreed that she had not had any significant issues with cognition before this happened. And then over time, her hallucinations actually resolved without really any significant intervention. So we thought that that probably this was caused by this thalamic stroke. It is common for people with strokes to have some improvement over time. So that may be why her hallucinations got better without much, in the way of intervention for those. But that kind of an interesting case, and again, a good example of how when, lots of times when we see somebody in the ER or in clinic who just has confusion, we're not really thinking that they could be having a stroke, but it's definitely possible. So moving on, sleep disorders are very common in our patients with cognitive disorders. So sundowning and circadian rhythm dysfunction, so kind of getting days and nights mixed up, are very common in lots of different dementias, but especially Alzheimer's. Lewy body dementia is commonly associated with REM sleep behavior disorder. So these are people who are like kicking and screaming in their sleep. There have been associations demonstrated between vascular dementia and sleep disordered breathing. And then sleep disorders may also increase the risk of cognitive decline. So kind of chicken and egg. All of these sleep disorders have been associated, at least in some studies, with cognitive impairment. So again, with a lot of these, the data is a little bit mixed, but insomnia has been associated in some trials to be associated with worse cognition. Poor sleep quality and sleep fragmentation have also been associated with increased risk of cognitive impairment. Disruptions in sleep duration, so either too short or too long, have both been associated with cognitive dysfunction. And then sleep disordered breathing, so like sleep apnea. And sleep disordered breathing has also been associated with increased accumulation of white matter lesions on MRI, which may be reflective, again, of its kind of also association with vascular issues like obesity and things like that. And then there have been a few trials that have suggested a possible role in treating things like sleep apnea with CPAP in patients with Alzheimer's, and that there may be possibility for some improvement in some cognitive domains. Mood disorders, so again, the data is a little bit mixed and there's some discussion about, again, sort of chicken and egg, but there have been several large studies suggesting increased risk of the development of mild cognitive impairment and the progression from MCI to dementia in patients who have depression and anxiety. Dementia may also lower cognitive reserve, so make it a little bit more challenging for patients to cope with symptoms. And then there's also been some consideration of depression as a prodromal symptom of dementia. So again, maybe not always causative, but sometimes a symptom of the disease. And then medications, whoops. So this medicine list here is the medicine list for the case I talked about earlier. So this is that 80-year-old woman who had a stroke, and I thought this was a very good illustration of how sometimes we are dealing with a lot of multifactorial issues in our patients. So common medicines and toxins that are associated with cognitive issues would be sedating medicines, so like narcotics and benzodiazepines, anticholinergic medicines like tricyclic antidepressants, antihistamines like Vistaril, which, you know, I love to use that for sleep and anxiety in my young patients with MS, but I get much more concerned about it in my older patients with cognitive issues or who are at risk for cognitive issues. And then alcohol abuse. You know, alcohol can be associated with cognitive issues, but then can also increase risk of nutritional deficiencies in things like thiamine. So this is probably small, but again, I think this is a good example. So this woman was on aspirin, antihypertensive medicines, which again are reflective of her underlying other comorbidities, hypertension and hyperlipidemia, and then, you know, her prior history of stroke. She was also on B12 supplementation, so potentially a prior nutritional deficiency there. Prozac, so again, underlying depression may contribute to cognitive issues. She had a lot of issues with chronic back pain. She has a lot of degenerative disc disease, so she is on gabapentin and oxycodone and tramadol for pain. So those all three would be a little bit concerning about the risk of cognitive implications. On Synthroid, so hypothyroidism, and then also on oxybutynin for bladder issues, which it has anticholinergic properties. So again, it gets very challenging because we can't always stop all of the medicines that may be contributing to someone's cognitive impairment, but it is important to consistently be evaluating medication lists and trying to tweak things if we can. And then I'm just going to briefly touch on a couple of other comorbidities. So epilepsy can cause cognitive dysfunction just by itself, but then also may be associated with increased risk of cognitive impairment and dementia, especially in older adults with epilepsy. And then I threw in just a couple of genetic conditions. So with trisomy 21 Down syndrome, there's a very high prevalence of young onset Alzheimer's disease. I think pathological studies have demonstrated that almost all patients with trisomy 21 will have some Alzheimer's pathology on autopsy, even as young as 40 or 50. And then CADASIL is another rare disease that can present with a lot of headaches and neuropsychiatric symptoms and can also cause cognitive impairment. So I think about that when I'm seeing younger patients who have a lot of neuropsych symptoms or who have a family history of neuropsychiatric disorders and migraines and lots of white matter lesions on their MRI. And then we'll touch briefly on social issues. And I think this is an area that is becoming increasingly recognized as important in cognition. So lots of different social issues have been associated with risk of cognitive impairment, including level of education, income volatility, and things like social isolation and loneliness. So those are important things to think about as well. So when we are evaluating for comorbidities, obviously you want to evaluate for vascular diseases, mood and sleep disorders, reviewing medications. I added a couple more in here in relation to anti-seizure medicines too. So like topiramate is an anti-seizure medicine, and we also use it lots for headaches, but definitely a lot of people report brain fog on topiramate. And then obviously gabapentin, which I actually will use it not infrequently in older people with epilepsy, because we can, start at really low dose and titrate slowly, and you run the risk of causing sedation and issues with that too. So I have to be careful about that. I mean, you can screen for other reversible things like B12 and TSH, and then screening for substance abuse and social issues. And then opportunities for intervention. So obviously we can help to treat underlying mood and sleep disorders, and then optimize management of vascular risk factors and stroke prevention. Exercise has been shown to be helpful in lots of different cognitive disorders and may also have a benefit in fall prevention, assuming that one is exercising safely. But that's another, again, opportunity for intervention, because if we have a patient who has some cognitive impairment and they fall and hit their head and have a bleed, then they're obviously going to be in a worse situation. We usually recommend about 30 minutes 3 times a week as a goal. And then diet. So again, what I typically tell patients is diets that are healthy for your heart are also healthy for your brain. So we typically recommend kind of Mediterranean style diet, which has been studied in trials before, and there have been cognitive benefit, or a suggestion of benefit in some cognitive measures. Smoking cessation and social resources are also important. So to close, I'm going to talk a little bit about this commission report, which was published in Lancet last year. And it was a dedicated group that was convened to make some recommendations about risk factors for dementia that we can modify. So there had been some guidelines published in 2017. And then in this updated guideline, they added 3 new risk factors. So the risk factors were education, hypertension, hearing impairment, smoking, obesity, depression, physical inactivity, diabetes, and infrequent social contact. And then in 2020, they added alcohol consumption, head injury, and air pollution. And there was an estimate that modifying these 12 risk factors on kind of a population basis could potentially prevent or delay up to 40% of dementias. So first, I think it's important to think about that, especially in the setting of primary care, where I think sometimes it is probably difficult on a day-to-day basis to see the big picture of how vital what you all do as primary care doctors is. And a lot of a lot of these problems are things you may never be seeing in certain patients because you have successfully prevented them by addressing all of these issues before they cause problems. So first, I think it really speaks to the importance of primary care. And then again, also, I think it's useful to think about these are things that we can intervene upon. And so the specific guidelines or actions that they recommended were to aim for a systolic blood pressure of 130 or less, starting in midlife, because those associations between blood pressure and cognitive dysfunction have been associated not only with late life hypertension, but also midlife hypertension. To encourage the use of hearing aids for hearing loss, again, because when you're getting less hearing stimulation or not able to participate as much in social interactions, and that potentially could lead to more social isolation and affect your cognition as well. Reducing exposure to air pollution and secondhand smoke, preventing head injuries, limiting alcohol use, and avoiding smoking. And then again, this, making sure we're providing all people with early educational opportunities is maybe something that's a little bit difficult to do on a day-to-day basis in the clinic, but is useful to think about in terms of, society-wide changes that we could make that could potentially make a big difference. And then again, weight management and diabetes, and then evaluating things like sleep and other lifestyle interventions. And then the last thing that they recommended was, again, for us, and again, this is not always easy to do on a day-to-day in the clinic basis, but sort of our role is in healthcare in general, but is the role of inequalities and risk of cognitive issues. So I sort of talk a little bit about, trying to improve healthcare equity and to make sure that we're addressing these needs in some traditionally underserved populations as well. Okay, so thank you very much for listening. So this is my own grandmother. This is not a random old person picture. So she is no longer with us. She died when I was in medical school, but she was 85 when she died. I put this in here as just an example of comorbidities. She had diabetes, she had hypertension, she had atrial fibrillation, she smoked like a freight train. She actually didn't drink. This was kind of us just making her look funny for this picture. She was perfectly cognitively on board with this picture, so we weren't just making fun of my old grandma. But anyway, I thought that she would actually really be happy to have this picture included in this slide because she was a pretty funny lady. So anyway, all right, so that's what I have, but I'm happy to take any questions.
Thank you so much, Dr. Ward. That was excellent, and I really love that picture.
Yeah, I think you can sort of get a sense of how I became the way I am when you see this. That's my grandma.
That's amazing. Does anybody have any comments or questions? Or Dr. Keith, do you have anything to add?
Melanie, this is Dr. Miller. I want to move to England where 21 drinks a week is okay.
Yeah.
That seems a little high by our standards. But
yes, so I did think about that actually. And it's 21 units, which I am assuming is the same, as our equivalent of, a unit and a drink is the same. But I was like, well, heck, we're probably doing better than we think over here in the US if that's the standard. Yeah, so they recommended less than 21 drinks, 21 units. I will need to verify if a unit is equivalent to what we consider a unit, but yeah.
One other question, do you recommend multiple vitamin mineral supplements for your demented patients?
So I would not say that I routinely tell everyone to take one. I do check B12 on everybody, and then if there's any risk factors for thiamine deficiency, I do. And then what I tell most people about supplements in general is, it's probably not harmful, especially to take a multivitamin. It's also probably not harmful to take some of those supplements that are specifically marketed towards memory, like Prevagen. But at the same time, for those specifically, there have not been large randomized clinical trials demonstrating benefit, and they're expensive. So I tell people, if you want to take it and feel like it makes you, it's satisfying to you to take it, then you can. But if you, it's not something I routinely recommend. But I do supplement, and we touched a little bit on this last time I presented too. I tend to start B12 supplementation, just oral, for anybody who's under 400.
Thank you.
And Jen, I see that you unmuted.
Hi, I'm Jennifer Boyd. I'm a physician assistant in Fayette County, and I couldn't join on time to hear your whole talk, Dr. Ward, but what I caught was really great. And I love it that you include early childhood education as part of our prevention. I have one question and one comment, I guess. Just this week last week I got a portal message from a patient whose father had Parkinson's related dementia, and she was asking me about, is there any screening for her? And so, and so my question is there any screening? And obviously Parkinson's or not, those risk factor modification recommendations would apply to her, but is there anything in particular that I should tell her?
So definitely exercise and diet, not only in the prevention of dementia, but also the exercise especially can be very helpful in motor management of motor symptoms in Parkinsonian patients. So all of those lifestyle things are important. In terms of screening, so I in my regular clinic, so we're obviously doing cognitive screening on everyone we see in our dementia clinic, but in my regular neurology clinic, I don't always screen every patient formally for cognitive issues. I do ask about it. And then it's usually, relatively easy enough to do a quick MMSE or MOCA on someone, which may not always be helpful, especially if they're not having any symptoms. They may very well be within the normal range, but it can be useful to follow it over time if they develop concerns. So like, let's say for my MS patients, lots of times I'll try to do some form of baseline screening so that we at least can know what to compare to when it's 3 years down the line and they're having a little more issues. I don't know that I would get dedicated neuropsych testing if she's asymptomatic and doesn't have any other Parkinsonian symptoms, but a brief screening thing like an MMSE may be helpful. If nothing else, also sometimes it's just helpful to reassure the patients, or sometimes you do an MMSE or a MOCA and you find deficits that you are not expecting to find, and then that leads you down a whole different route. So it can be helpful for multiple reasons.
I think she was wondering too about like genetic testing.
So that's kind of a fraught topic. With Parkinson's, I'm not a Parkinson's expert, so don't quote me on this, but the genetic relationship is not as universal. So I probably wouldn't do genetic screening. And then even for these more, like Alzheimer's and genetic forms of Alzheimer's or variants that increase the risk of Alzheimer's, you have to be very careful when you're doing genetic screening, because one, not everybody with the genes will manifest the phenotype. So just having the gene doesn't universally mean you're going to develop symptoms. And then also that then has implications for not only the patient, but their children.
Can I comment?
Yes, please.
There is one locus that could be useful in the genetics of Parkinson's disease. It's called LRRK2. But it's only useful really if there is a family history. It increases the risk of Parkinson's disease about 50-fold compared to the normal population. It is most often found in people that have a first-degree relative with Parkinson's disease. It doesn't change the clinical course particularly, and because it's not an autosomal dominant-like effect, it's probably not generally worth doing except in a research setting. In terms of Alzheimer's disease and frontotemporal dementia, it's really boils down to whether you have a significant positive family history. Currently, there is now over 80 loci that are known to be risk factors for Alzheimer's disease, where genetic variants that are common in the genome affect the risk, but they affect the risk just teeny amounts except for ApoE. And ApoE is generally not, we don't encourage people to do testing for that. And so it's really, it's more of a research occupation than a clinical thing, unless there's a serious family history. And in general, I actually kind of discourage people from getting tested just because they're curious, because it doesn't affect a single person. It affects a family. And you know, finding out results and spreading across the family when they don't want to actually know about the risk is actually can be prosecuted as assault if you force them to learn things that they don't want to know that affect their thing. And so if you're going to do genetic testing as carrier testing, someone should go through genetic counseling with someone that's sophisticated in this. And I used to do it all the time for patients that were referred to UNC. But in general, you know, doing it just out of curiosity is the wrong answer.
Yeah, I definitely agree with that. I would say in my general clinical practice, the only genetic testing that I send on even a somewhat regular basis, and by that I mean like once every year or two, would be Huntington's genetic testing. And those are people who have very strong family history, typically who are starting to manifest some symptoms, which there's obviously a lot of cognitive issues with Huntington's too, but I try to get genetic counseling for everybody before I send any genetic testing. It's not always possible, but I try to be as comprehensive in counseling them about not only the implications for them, but for everybody who came after them too. And then the neuromuscular people send a lot of genetic tests for things like, you know, hereditary neuropathies, but that's something I'm very bad at. I won't comment on that.
Yeah, to be clear, I would send her for genetic counseling. I wouldn't do genetic stuff, but and her dad, it was her dad who had the Parkinson's. But anyway, well, that's helpful. Thank you both. My comment is about hearing loss. I mean, I just think hearing loss, to me, it's almost unbelievable, and it's without a doubt unconscionable, the disability that we accept in older people, that were it vision, we would never tolerate that level of disability. And so does anybody, it just seems that hearing aids are not helpful. It seems that there is not a collective societal consciousness about how pervasive and dangerous hearing loss is. I see it as dangerous, and for many reasons, social isolation being one, but just inability to communicate with important people in your life, and people who have zero cognitive impairment, and end up seeming to have cognitive impairment because they can't hear. And I just get very upset about it. So
yeah, I agree with you on that.
Any miracles out there for patients with hearing loss?
Yeah, it's a challenge. Also, you know, it's something that's not always as easy to formally screen for. I mean, you know, we can test a patient's hearing sort of briefly in clinic, but we can't do dedicated audiograms and things like that. I do think it's a challenge, and it's difficult because sometimes patients seem confused when really they just didn't hear what you said. And then the other thing is, when they're aware that they can't hear very well, sometimes they sort of, you know, retreat to within themselves or isolate themselves a little bit because they're embarrassed to say, I didn't hear what you said, or I can't understand. So it is definitely a challenge, and it's not always easy to get somebody access to hearing aids, especially in people who are underinsured, and then also to get them the appropriate hearing aid to actually improve their function as well as we'd like can be hard. I don't have a great answer for that, except that, you know, it is something that should be addressed on kind of a larger scale.
Dr. Hott and Dr. Williamson, I saw you guys both unmute.
I don't have an answer for it either, but I would point out that a substantial amount of complaints about hearing are actually not necessarily because of problems with the ear, and amplification doesn't necessarily help. They're very often cognitive. In fact, there was a study done that I thought was pretty interesting where they recorded voices of people and they played them to individuals to ask them meaning, and then they mixed them together. And it turns out when you mix them together, we normally can sort out who's saying what. And it often helps if you've heard the voice of either of the individuals beforehand. But patients with Alzheimer's, it doesn't help. They don't disentangle the voices. And so they need an environment that's where there's very limited input other than what they want to hear. And so, you know, a lot of older people complain about when they go to restaurants, how awful it is if it's a noisy place. But sometimes it's even worse because their brain just doesn't disentangle that. And none of the hearing aids basically disentangle the sound, unfortunately.
I could just add a couple things. That's very interesting, Kirk. Just for those who can't afford them, the Lions Club, LYONS, will give you one free hearing aid. If you have a local one, you can check with them, see if they participate in that program. Also, the vets will provide them. And, you know, they're primitive types of hearing aid, which just sort of amplify everything. And then the newer ones have these circuits and chips in them that sort of filter out everything except voice-related frequencies. So they tend to be better. So if they had an earlier one, a newer one might make a difference. Also, some people just hate wearing them. They can't figure out the little batteries. They lose them. They're hard to fit in. So some of the newer ones have built-in rechargeable batteries, which is easier. You don't have to buy batteries. And a few people who can't hear the phone, they do have an adapter for your phone that has a flashing light instead of a ring, so that at least you don't miss your phone calls if you can hear at all on your phone with turning it up. So those are just some of the things I try to convey to patients.
Thank you so much. And then I think I see both Teresa and Dr. Hott. Dr. Hott, did you want to chime in really quick since you had it unmuted, if you had anything else?
No, I'm good, thanks.
Yeah, you're welcome, of course. Teresa.
I was just going to add, Dr. Wilhelmsman spoke of the environment in which, you know, you're speaking to someone with dementia. As a speech pathologist, you know, of course, there are those communication tips of, you know, speaking directly in front of them, making sure that the background noise is limited. But something I always like, especially to offer practitioners or clinicians, are the pocket talkers. And you can actually keep those just in your office. And you can just, you know, put the mic on you and the amplifier maybe on the person you're seeing, and it just amplifies you. I also recommend those, you know, to caregivers and families of someone that's having that issue, but they're not too expensive. You can probably find them on Amazon. But, you know, that's something that the clinician can kind of take control of. And, you know, at least in your environment, they might be able to hear a little better. And again, it doesn't work for everyone, but it's just kind of another tool to have in your pocket.
This is a picture of them. They're made by Radio Shack. Mm-hmm. This is a little microphone in here. So you hold this, put the headphones on the patient, and then you don't have to scream in their ear. You can turn this up and fiddle with the tone control till they can actually hear you. And I had a very interesting case one time with a resident who they thought the patient was mute and very demented in a nursing home. and her hearing was so poor, she couldn't barely hear anything anybody said. But when I put this on her, I could say, "What kind of ice cream do you like?" She said, "Chocolate." So here's a woman who never had any verbal output because everyone assumed she was deaf when she just had, severe hearing loss. And if you had this, you could communicate in a basic way. And it also makes you sit in front of them and look at them when you're talking so that they, get your attention and keep it better. So I always have one of these in my office and take it when I have really bad hearing loss. You can order them online, through Radio Shack they're like $30 or something.
It's so interesting, and people could buy one for themselves and take it to all their doctor's appointments.
Yes. Or even just at home, if they hate hearing aids, but you really want to communicate with them, instead of turning to the side and screaming in their ear, at least you can do this face to face with them. Yeah.
That's excellent. I love that. I had a friend and her father had really poor hearing, and he had these like headphones for the TV because they both wanted to watch TV in the living room, but he wanted to have it, so loudly that everybody else would be like bleeding, by their ears. And so like giving him a hard time. So finally, like he has these awesome like headphones. I don't even know how it works, but it connects to the TV so he can adjust how loud it is for himself. And we can all like, sit in the living room together and watch something with him. I have another family member I would love to give that to, but they're a little more sensitive about that.
Yeah, it's a Bluetooth connection so that you plug something in your TV and it goes wireless to these headphones. So you can turn them up all the way you want, but the other people in the room aren't blasted out.
It's excellent. Maybe like Best Buy or something,
Thank you all.
Amazon has everything these days.
Thank you so much, everybody. This has been a great discussion. Does anybody have any further comments or suggestions or anything?
Thank you all.
Thank you, Dr. Ward. Thank you, Mark, for the claps in the back. You could use your little reactions. I love these things. I don't know why. Anyhow, I guess I'll just make that announcement, give you guys a little bit of time back to your day. We just have our next session. It's going to be July 6th with Kirk Williamson discussing behavioral and psychological symptoms. So we really look forward to that. If you need anything or have any questions, please don't hesitate to reach out to one of us. And again, it's a joy to see you all. I hope you have a great rest of your day. Thank you so much.
See ya.